Okay. Welcome this morning. We appreciate we have many more people online than we have here in the room. I'm Corey Robinson Rosenberg and was actually a team member on this project. But what I want to do now is introduce you to the principal investigator, Dr. Carolyn D. Giuseppe, is a professor of epidemiology in the Colorado School of Public Health and professor of pediatrics in the School of Medicine at the University of Colorado Anschutz Medical Campus. She received her medical degree from the University of Virginia, Master of Public Health from the University of Washington, and PhD from University College London. Dr. D. Giuseppe has published some 200 journal articles, book chapters, technical reports, and scholarly reviews, many related to autism spectrum disorder, phenotype, and etiology. She serves as co-principal investigator and epidemiologist for the study to explore development, was the principal investigator for the screening and linkage to services for autism trial, and is currently collaborating with investigators at Columbia University to examine injury-related emergency department visits and hospitalizations among children with ASD. So with that, I'd like to welcome Dr. Giuseppe to the podium.
Even I can't pronounce it sometimes. Hi, welcome to those in the room and to those online. Thanks for inviting me here to present about our randomized controlled trials, the SALSA trial. My plan today is to briefly explain what family navigation is and its potential role for young children who have autism spectrum disorders or potentially have autism spectrum disorders, and then describe the results of our trial. In particular, the barriers that some of the families encountered in trying to obtain evaluation and services for autism spectrum disorder, how the family navigators were able to assist the families, and then what were the effects of navigation on our outcomes. So this is a collaboration among 4 different institutions, the University of Colorado Anschutz here with several different schools on campus, Denver Health, which is a major provider in Colorado of care for uninsured and Medicaid recipients, Rocky Mountain Human Services, which provides Part C early intervention services for infants and toddlers who are resident of Denver City and County. And they also have a specialized clinical team that provides evaluation for children who potentially have autism spectrum disorder. And then finally, we collaborated with the then director of El Grupo Vida. This is a network of Hispanic and Latino families that provides support for persons with disabilities and their families. So that's the group. So just brief background on screening for autism spectrum disorder. So there is some evidence that young children with ASD can benefit from early detection, treatment, and services, but most are not diagnosed until they are older than 3 years of age. Studies have also shown that if primary care providers during well visits do routine screening for ASD, that there is an increase in early recognition. And for that reason, the American Academy of Pediatrics and other organizations recommend routine screening at the 18 and 24-month visit. However, even when children are screened at their primary care visits, many don't actually then receive referrals for evaluations, don't get the evaluations, don't get linked to services. And that's especially true for minority, foreign-born, low-income, and less educated families. They have less information about ASD and about early intervention and obtaining care. They describe a lot of barriers to obtaining care across a wide range of different issues. They are more likely to report that they actually expressed concern to their provider, their pediatrician, but the provider dismissed their concerns. And then there's a lower level in general in that population of trust in the healthcare and educational systems, which could be a barrier to obtaining evaluation and services. And then even if they do get evaluated and into services, they report lower levels of satisfaction. So for all of those reasons, these families tend to get referred, diagnosed, and into services later when the child is older, if at all. So one possible solution, we thought, was family navigation. So patient navigation was originally developed to address important disparities in cancer care, where patients who had positive screening tests for cancer encountered barriers to obtaining the timely diagnosis and treatment. So patient navigation was intended to help those patients sort of negotiate the system. And it's also been since used to improve management of other chronic diseases in adults, and has been studied in a few pediatric populations, mainly around improving delivery of preventive services. And it has been effective in doing so. So we thought the potential role for an autism family navigator would be to provide education to families about autism, about early intervention and services, and then help them to coordinate their care, again, navigating the system to obtain evaluation and services. Also, navigators can coach families to advocate for themselves within the system and make sure they get what they need, and can offer support to the family and assist with some of those practical and logistical barriers that I mentioned previously, like transportation and financial barriers. So this was the two main aims of our trial. One was to examine the effect of autism family navigation on referral, on evaluation for ASD, and on linkage to services in a largely minority disadvantaged population. And then also to examine how well we reached families within that population and what the implementation looked like in that setting. So this study was implemented in Denver Community Health Services. This is a network of about 10 community health centers and about 20 school-based health centers that are located throughout Denver that provide primary care. Not all of them provide care to children, but most do. And as I mentioned, Denver Health generally provides affordable health care for low-income populations. And in fact, this population, the large majority of patients seen at Denver Community Health are low-income and minority. So right around the start of the trial, Denver Health implemented routine screening for ASD. And their standard plan was ASD screen implemented at the 18 and 24-month well visits in the primary care clinics that serve children. And they used the modified checklist for autism in toddlers revised with follow-up. It's a mouthful, so I'm gonna call it MCHAT after this, which is a two-stage parent report screening tool that identifies children who are at risk for ASD. If the child scores 8 or higher, they're considered high risk for ASD, and the recommendation is that they be referred immediately for evaluation. Moderate risk, the MCHAT has false positives. That is, some children who screen in the moderate risk range are not at risk for ASD, and therefore the recommendation is to do follow-up questions which can increase the specificity of the instrument. And then if that's positive, then refer for evaluation. And then if the score is low, no further evaluation is needed unless it's the 18-month visit. So having a low risk score in 18 months doesn't mean they won't have a higher risk score at the 24-month visit when more symptoms may manifest. So that is a recommendation to rescreen still at 24 months. So this was our study population. We had a little bit wider age range than 18 to 24 months because some children come in a little bit early for their 18-month visit, and certainly some children come in late for their 24-month visit. But we did want to catch children while they were still young enough to be able to be evaluated and served through early intervention, which goes up to 3 years of age. They had to be seen for a well visit at Denver Health primary care clinics. And the initial score, that moderate risk or high risk or low risk, had to be at least 3, indicating moderate or high risk. And it had to be recorded in the electronic health record. Obviously, you don't screen children who you already know have ASD, so we didn't include those children. And then because Rocky Mountain Human Services only serves children who are resident in Denver City and County, we excluded children seen at Denver Health who were not resident of Denver City and County. That's about 1/3 of their child population. So if you look at the screening to services flow, you can see how there might be some difficulties for families in negotiating this process because there's a lot of steps involved. If they have that initial MCHAT, and if it is moderate risk, they need to have the follow-up actually done. The provider needs to actually make the referral. The family who's been referred has to make it to and complete the child find evaluation. And then if the referral specified that the child needed evaluation for ASD, then they need to also arrange and get the ASD evaluation, and then get the individualized family service plan and link up to services. So it is important to note that if the referral is made but doesn't specify the need for an ASD evaluation, then the child won't necessarily receive that evaluation. So barriers could potentially operate at all those different steps, and those are where we thought that a family navigator might potentially be able to act. So we had 2 navigators over the course of the trial. Both were bilingual Latina staff members who were housed within Denver Health. And they underwent extensive training for navigation. First, they underwent the standardized training that is used for all patient navigators, including those managing cancer care and other disorders, which includes extensive modeling, practice, and feedback around the various skills that you need to be an effective navigator, like communication skills and care coordination and providing support to the families. We also developed some training that was specific to our project around autism spectrum disorder. Information about the disorder itself, the screening tests and diagnostic tests, about early intervention and how that works, and sort of an orientation to Rocky Mountain Human Services in Part C. So this is the design of the trial. It looks a little complicated, so I'm going to walk you through it. So as I said, we had eligible children, 16 to 30 months, MCHAT-3 or higher, resident in Denver County. That determination was made at the administrative record level by an independent analyst who applied an algorithm to identify all children who met those criteria and randomized them at that point to intervention or control. We had no involvement at all with the controlled children. We didn't talk to them. We didn't look at their records. We didn't reach out to them. So they were really just the standard routine care for children at Denver Health who had an MCHAT of 3 or higher. For the intervention group, the navigator would then review the electronic health record. So if the child had an MCHAT in the moderate risk range, but the follow-up questions were negative, then she did not offer navigation. The only thing offered to that family was if the child was 18 months, she would follow them and make sure they came in at 24 months. If a referral was definitely needed because of a high risk score or a moderate risk with positive follow-up, then she would offer navigation to those families. And then there was this third group where they had a moderate risk score, but the follow-up wasn't done. So she would then contact the family to try, and or the providers or staff to try to assist in the process of getting that follow-up done. And then if it was positive, offering navigation, and if it was negative, not offering navigation. So if a referral, sorry, and I should point out, there were a few families that never got the follow-up questions even though they were supposed to, but they got a referral anyway from their provider, and she offered navigation for them as well. So if a referral for early intervention evaluation was made or offered or was needed to be made, even if it hadn't been made, she would telephone the family. So this was happening several days after their visit. She would call the family, obtain consent for navigation, and then interview them about barriers to care. If the indicated referral had not been made, either had not been made at all or had been made but didn't specify ASD evaluation, she would contact the provider to try to ensure that the appropriate referral was made. And she would also coach the family to advocate for themselves to either contact the provider and try to get the referral, or to request an evaluation, which parents can do under Part C. And then she would assist the family with resources, care coordination, and so forth as they went through the process, maintaining ongoing communication and support. So that's sort of the general overview of the procedures.
Did Navigators,
Oh, I was gonna say I could repeat it, but go ahead.
did Navigators ever do that along with the patients? For whatever reason, saying contact the doctor didn't work, so hey, let's call them together,
Yeah.
or let's email them together. Did that happen sometimes?
Yes, definitely. She would sometimes be on three-way calls with both the providers and also with Rocky Mountain Human Services care coordinators as well. Okay, so what were our primary outcomes? So our primary outcomes were all the places that family navigation could potentially show some kind of benefit. That is, with navigation, we might see more children getting the completed two-step with follow-up. We might see more referrals, more completed child find evaluations, more ASD evaluations, more individualized family service plans, and referral for services. So those were the primary outcomes. And we also looked at barriers experienced by families and the implementation of navigation. Our primary outcomes were all based on linked electronic health and early intervention services records. So they do rely on the completeness and accuracy of the records maintained at Denver Health and at Rocky Mountain Human Services. So those records were linked together to see which children who had the original MCHAT score of 3 or higher then got referrals at Denver Health, had child find evaluation, had ASD evaluation, and so on. To identify barriers, as I mentioned in the initial phone call, we did semi-structured interviews that were standardized to ask about particular types of barriers families felt they would encounter, and these were coded. In addition, the Navigator kept records of contacts with the family and the activities that they implemented, and they also recorded additional barriers that the families encountered over the course of the process. So the primary outcomes were compared between the originally randomized groups based on intention to treat. That is, we compared the children randomized originally through the electronic record to intervention or control, recognizing that some of those children would not eventually need evaluation in both groups. Some would not get evaluation, and we would maintain our randomization. And then the effects of the intervention were estimated using log binomial models to get relative risks. We tabulated and categorized, we categorized and tabulated the barriers that families experienced who were consenting to navigation, and then also did the same with the Navigator activities. And so I'll be presenting those results. Okay. So first, the initial randomization. There were 275 children over the course of the trial who had an initial MCHAT of 3 or higher, and were randomized in approximately equal numbers to the intervention group and the control group. So remember, we didn't have any further contact with the control group, so I'll just tell you, oh, sorry, I wanted to mention the characteristics of the two groups. So these are in the originally randomized groups, and you can see a couple things from this slide, that the groups look very similar in terms of the characteristics: age, sex, race, ethnicity. You can see that a majority were Hispanic ethnicity, and a majority were male as well. And then they were also similar in their household language and whether the child was on Medicaid insurance. You can see that was almost all of our sample. We looked at whether the children had any other existing complex chronic condition that could potentially be an additional barrier. That was similar between the two groups, as was poverty level. Excuse me. So that shows that our randomization was successful, that the two groups at baseline looked very similar in the characteristics that we had information on. And they were also similar on their MCHAT scores, with about 10% scoring high risk. In the early part of the trial, providers at Denver Health had an option. Instead of recording the score, they would just record pass or fail. And a fail meant a score of 3 or higher. So now those children would still have the MCHAT in the file that could be reviewed manually, but the fail was seen in about 10% in each group also. So those were anywhere from 3 up. Okay, 142 children randomized to the intervention group. So about half did not actually need navigation, and we knew that because they had a follow-up that was negative. So they had an originally moderate risk and then a negative follow-up. There were about 15% where they never got the MCHAT follow-up despite the efforts of the navigator, and they also didn't get referral. So we didn't navigate for them because we didn't really know if they needed referral or evaluation. A handful were not eligible for various reasons. So out of our randomized children, about 46, or about a third, were potentially eligible for navigation. So those were the ones who were who an attempt was made, I should say, to offer navigation. And about half consented to navigation. So we had 22 families in the end who had consented to receive navigation. Only a handful of children were actually reached that families were reached that refused, and almost all of those, their children were already in early intervention services for prior developmental delay, and the families didn't feel they needed help with navigation. But there were about a third that we were not able to contact. A few because they were in foster care and we didn't have access to the parent, and then the rest we just couldn't reach despite multiple telephone calls. These families each got at least 1 home visit. They got at least 1 letter. So we tried different ways to reach them, but we're not successful. So what did the consented families look like? I wanted to see how they looked compared to the other children in the intervention group to see if we were reaching a different population. In terms of age, sex, Medicaid insurance, chronic medical conditions, the groups looked pretty much the same. But we did see some differences in who consented to navigation in these characteristics. Now, the higher MCHAT score is not surprising because we only offered navigation to the families whose children had moderate or high risk, and you'd expect more in that group anyway. But we also saw that white Hispanics who spoke Spanish were significantly more likely to consent to navigation than families of other ethnicities, races, and languages. When we interviewed our families, we were able to gather some additional information. The previous slides were based on what was in the electronic health record. So when we interviewed the family, we asked about native language, not just what the family indicated they could understand, but their native language, as well as education and income. And certainly we were reaching the population that we were interested in, families who were minority, low education, low income, foreign born. So that was the majority of our sample. In part to help with the navigation, we asked them what language they preferred to receive how they preferred to receive new information in terms of language. And about half preferred Spanish, and another substantial proportion said English or Spanish, and a minority preferred receiving it in English. In terms of the preferred method for learning about their child's health, most preferred either person-to-person or watching videos, rather than something in writing or particularly the internet, which probably reflects both language and literacy issues in our sample. Yes?
Check. How is watching a video different from the internet website? Was the video not?
We just asked them on the telephone, how would you like to receive information? So we just said, watch
It
videos
wasn't
or
provided, it was just questioned.
correct. Yeah. And it could also be access to the internet. So, but they can see videos in the clinic, for example, or at Rocky Mountain Human Services as well. There's other ways to see videos besides the internet. So those were asked separately. Okay, so now I want to tell you what some of the families talked about in terms of their barriers. We broadly categorized the barriers into groups that included pragmatic barriers, informational barriers, and beliefs and attitudes. So pragmatic barriers were the most common, particularly scheduling problems. Now, sometimes the navigator reached the family some weeks after they had already been referred, for example, and so they had already perhaps started on the process of trying to obtain an appointment with early intervention, and there were a lot of difficulties families encountered in terms of difficulties scheduling it or forgetting about it or having one set that they didn't realize that they had or they just couldn't take off work. The process was a care coordinator from the early intervention agency would reach out to the family, and sometimes they would leave a message. Sometimes that message was in English, so there would be a delay while they translated, or they would say, here's your appointment, but that wasn't a time that they could make. So there were just difficulties. And then if the family spoke Spanish only, there were problems for them in trying to then talk to Rocky Mountain Human Services to schedule a different time. A substantial portion, but much smaller, had transportation and insurance needs. For example, they had difficulty reaching the facility for the child find evaluation by bus, or they didn't have bus fare, or they needed taxi fare, or they wanted to, they were concerned about whether Medicaid would cover the evaluation, not being aware that they didn't need to have Medicaid to receive an evaluation. And then smaller numbers had medical needs and physical needs that were potential barriers. In terms of informational needs, about half requested information, said they didn't understand a wide range of things, from why they even got the MCHAT in the first place, what it was, what the results meant, what autism is, why they were referred, what was supposed to happen after that, what they were supposed to do. And we did see important differences by language in informational needs. About 2/3 of the Spanish-speaking families expressed informational needs, and only about 1 in 6 of the English-speaking families. So there was a real difference in who had these kinds of informational needs. Despite that, surprisingly, very few families said they needed help with translation or interpretation. So a little bit of a discrepancy. And then beliefs and attitudes covers a wide range of topics about their beliefs and attitudes about health or about the healthcare system. There was a group of families that actually didn't feel their child had a problem at all. For example, because their pediatrician had said they didn't seem bothered, or the child's, oh, sorry. Can they hear me now? Hear me now? Can you hear me now?
Right now. Testing. That seems to be working now.
It was working. It's just can they
Testing,
hear?
testing. You can.
Good now.
Yeah.
Okay. All right. So I won't use the lavalier. I'll stand still.
Well, or you can use this.
It's fine. No, I don't want to hold it. Okay. So, sorry about that technical glitch, everybody. Believes, so they felt the child would get better on their own, or, for example, the child's grandmother had said that the child was fine. So there were that kind of beliefs that were there. And then they also went in the other direction where they did believe the child had a problem, but there was nothing that could be done about it anyway, or they didn't want them to be labeled with autism because of the stigma. Yes?
But I wondered about following up with these questions after they got the evaluation, especially the barriers related to beliefs about autism, stigma.
And I would say the answer to that is no.
Okay,
So,
I would just be
we
curious.
did try to do some follow-up, but we got very few families and not enough to really do much with. There was
Okay.
a small number of families that we were
Yeah.
able to interview again.
Yeah,
at the
just
very
in
end,
case.
yeah. Okay, so, and then lastly, there was a set of families who felt that particularly because of their citizenship or their ethnicity, they wouldn't get an appropriate evaluation and felt that there would be maybe some discrimination there because of who they were. Let's see. Oh, now this doesn't work. Okay. This doesn't work either. There we go. All right. I'm really glued here now. I'll get to All right. Other barriers that arose and were identified during the course of the trial by the navigators and by ourselves as well were also important, hadn't been specifically stated by the families. One issue is definitely family mobility. If the family moved frequently, particularly if they moved out of the county, then they were no longer eligible for services through Rocky Mountain Human Services. Sometimes they would move out and then move back, but then they had to start all over with the case. They had to get a new referral and go through the process again. And then system barriers were really important, and they operated at both agencies. I've already mentioned some of them, like not getting the MCHAT follow-up, not getting the referral, having a referral that didn't say that ASD evaluation was needed. We also encountered providers who put what we called a hold on the evaluation. They would say, well, come back again in 3 or 6 months and we'll reevaluate. The problem there was sometimes the families did not come back. And so they didn't ever get that referral. And similarly, they had the screen at 18 months and never got the 24-month screen. The navigators the staff were trained at Denver Health to be sure that every child in the right age range got the screen with the MCHAT and that it was completed properly, but turnover of staff meant that new staff would come in who would not necessarily make sure the family completed the MCHAT screen or that follow-up was done. And then in the last 6 to 9 months of the trial, we encountered a problem where because of a shortage of clinicians, Rocky Mountain Human Services was not actually able to do ASD evaluations for quite a long period. And so families were told, it's going to be a year. We'll get you into services now. Some were referred to other sources to try to obtain an evaluation, and some were basically just on hold, on a wait list. So families reported quite a few barriers, but the range was wide. Some had very few, some had a lot. About half of the families experienced 5 or more different barriers to obtaining an ASD evaluation. So barriers were common and lots of barriers were common. So the Autism Family Navigators recorded a total of 54 unique different types of activities that they implemented over the course of the trial, which investigators in the trial categorized into these 8 different types of activities that are listed on the left side of this slide. And then over on the right, I've just given you some examples of activities that might have been categorized into those different activities. So for example, contacting the early intervention agency on a 3-way call to schedule evaluation was categorized in the care coordination group, or reminding families that they had a visit coming up. Another example would be a number of the families asked the navigator to come with them, saying they would feel better if she was there, which we categorized into social and emotional support. Or if she coached the families to request an ASD evaluation, which would allow them to obtain it, that was considered empowerment of the family. So these are examples of the different kinds of activities in each of those categories. And this shows the frequency of those different types of activities. Care coordination, by far the most common. Almost every family received some kind of care coordination assistance over the course of the trial. And I think that there was one or two who didn't, and I think they just said, I don't think my child has a problem, so I'm not going to pursue this. And education was also very commonly offered, both to those who'd requested it or listed it as a barrier, and as well over the course of the study, for example, helping them understand the results of the evaluation for ASD. A fair proportion, between 20 and 40%, had those more sort of soft support, like social and emotional support, advocating on the family's behalf, for example, talking to the provider and saying they really need to have this referral, or helping the family to request it themselves. Whereas the more sort of practical, logistical support was actually not very commonly needed or provided. So that was fewer than 15% for those different kinds. Yes.
Am I seeing? Check. Am I seeing correctly that the translator is somebody different than the navigator? So when they said for social emotional support, can you join me? I'll feel better. The navigator is present as well as a translator?
So this interpretation and translation would be if the navigator provided interpretation and translation. However, Rocky Mountain Human Services does provide an interpreter, usually, during the course of the evaluation. But sometimes they weren't there, they were late for whatever reason, or she would translate something else that they needed. They'd gotten the written evaluation, taken it home, and then they just didn't understand it. So this is only when she provided that service, because they could definitely get it through other sources. The navigator also did activities that were sort of not directed directly to the family. For example, training sessions. She did a total of about 20 different training sessions at Denver Health to try to train staff about autism and the MCHAT and making referrals. We produced educational bulletins that were distributed to providers. She tracked and gave reminders to ensure that follow-up screens were done. So a variety of sort of system level activities to try to improve delivery of ASD screening and follow-up. She also continued to work closely with Rocky Mountain Human Services to coordinate evaluation and services. And then they also participated in some community events to try to raise awareness about ASD and about screening and early intervention services, in part so that more families would say yes to navigation, and in part to address issues of informational needs and stigma. So here are our primary outcome results. We did see a significant increase in having a completed MCHAT-RF, so having the two-step follow-up. So completing that instrument with fidelity was greater in the intervention group. We saw really virtually no difference at all, or no difference at all, in the proportion of children who were referred for evaluation or referred for services. So that would have entailed sort of intervention directed at the providers, for example, and that was something that was a little bit harder to move in the system. A little more likely to complete the early intervention eligibility, the child find evaluation, but not significantly different. So the sort of basic connection to early intervention services, the navigator didn't have much impact on. But there was a significant increase in the proportion of children who were evaluated for ASD. So remember, this is intention to treat, so this is looking at all the children, many of whom didn't actually need an evaluation. This is the numbers, and you can see that children in the intervention group were about 3 times as likely to complete an ASD evaluation as those in the control group. They were also about twice as likely to receive an ASD diagnosis, although the numbers are getting really small at this point, and that was not statistically significantly different. I know you'll be interested to know the actual navigated families, the ones where they actually worked with, the 22 families. So obviously 100% of them were referred, partly because that was one of the indicators for needing navigation, but 73% of those received their early intervention evaluation, compared to about half of those who were referred in the overall group, in the control group. And then almost all of those who received an early intervention evaluation also either completed the ASD evaluation or were scheduled or on the wait list at the time the trial ended. And of those who completed the ASD evaluation, most of those, so 36% of the total, but about 75% of those who completed the evaluation were diagnosed with ASD, and all of them went on to initiate early intervention services. So if we actually could connect with the families, the Navigator seemed to have a lot of impact. It's that initial connection that was difficult. I think I'm short on time. Yes. Okay. Okay, so just very briefly, there's been one other trial completed looking at navigation that came out after our trial started. About 40 minority or disadvantaged children were randomized between groups, so about 20 children got navigation, and they found very similar results to ours. A large portion of the families experienced a lot of barriers, mostly pragmatic and informational, and they also found that children receiving navigation were about 3 times as likely to complete a diagnostic assessment and about twice as likely to be diagnosed with ASD. Roth is addressing something we didn't really address in our trial, but for your interest. She randomized, again, about 40 children who had already been diagnosed with ASD, and the purpose of navigation here was to try to help them actually get connected to services. And she compared early navigation a week after diagnosis to late navigation 3 months after, and found that early navigation significantly increased both scheduling and completion of appointments for the recommended services. Oh, sure.
Who administers the ASD evaluation?
So in our study, that was administered by a clinical team at Rocky Mountain Human Services with behavioral observation, standardized testing, parent interview. So in conclusion, we did find that disadvantaged families whose children screen positive experience a lot of barriers. And that wasn't surprising. I think that's consistent with the literature. Our navigators were able to provide a wide range of assistance, but particularly care coordination and education were the real major activities of our navigator. The intervention children were about 25% more likely to have a correctly completed 2-step MCHAT-R and about 3 times as likely to complete ASD evaluations. However, half of the families potentially eligible for navigation either declined or couldn't be contacted. But we did find that Latina Spanish-speaking mothers were more likely to engage with our navigators, who were also Latina Spanish-speaking women. So we think navigation is feasible and is effective in increasing ASD evaluation of at-risk toddlers in an urban sort of community health center setting that serves underserved. And it's effective in which could help to address some of the disparities that we see in obtaining diagnosis and services in this population. It's also effective in improving the quality of ASD screening, which could go both ways. It can reduce unnecessary referrals because of the false positives, but also it may be that it could increase referrals because a child who was moderate risk, who was also positive on the follow-up questions, the provider might be more motivated to refer. However, the low-income minority families do seem to be hesitant to respond to offers of assistance from navigators, which could reduce the impact of this type of program, and did seem to be more likely to engage with navigators who represented their own cultural and linguistic characteristics. And then so we suggest, so one of the things about our trial was that the navigators, because of the way the trial was set up, would call the families later after the visit. And so in this case, and that may have been a barrier to responding to the contacts. So embedding them in the clinical setting, so initial contacts are in person, might be more effective, or basing them on provider referrals. If my pediatrician said I needed navigation, I'd be willing. And to do that, then you have to make the navigator role visible to the clinicians, have them understand what the potential benefits are for their patients. Obviously, the navigator can't get in the way of the processes that are going on within the clinic or at the early intervention services, so they have to understand those processes, and they also have to maintain relationships that allow effective care coordination. And then we do think that conducting community outreach and partnering with community organizations could also be helpful in reducing stigma, enhancing trust in the navigation system that might make it more effective. I want to acknowledge the funders. 2, 3, okay. And this is our study team. You can see a lot of people were involved. The 2 people shown in bold are going to do some discussion today, and I'm going to introduce them. So, sure.
So the question online. Is the level 2 autism screener stat ever used after the MCHAT-R parent level 1 screener? And she says, I realize this screener is used for 24 to 36 months.
Not at Denver Health.
Yeah. Yeah, it wasn't. I mean, I think STAT has become more popular since the trial occurred. There's been more training and use of it, but it wasn't in much use that we were aware of at that time.
And I don't think, Meg could respond to it perhaps when she comes on, or Jody, but I don't think it's used now at Denver Health either, so, as far as I know, but I don't know that for sure.
Am I reading that correctly? Those are the names of the 2 ladies that were the Latina navigators?
Yes.
And one of them is a physician?
Yes.
Thank you.
She's a physician who was trained in her native country. Isn't practicing medicine here, but was student in navigation. Oh, sorry. Yeah, sorry. The question was about one of our navigators being a physician. She was trained in her native country, is not practicing medicine here. Is that it? Okay, all right. So I wanted to introduce my 2 colleagues. Dr. Jody Duling-Litvin is here. You can't see her because I guess I can stop. Oh, I can stop sharing the screen. So no, I'm just getting people. So, all right. So if I'm talking, no, I'm not getting my picture. No, you can see it. It's a little tiny box, but come on up. She is a clinical psychologist who oversees the early intervention and clinical services at a Denver not-for-profit organization, obviously our collaborator. After spending the past 25 years focused on provision of high-quality evaluation and services for individuals with developmental delays and disorders and their families, she is passionate about collaborating with others, looking to remove barriers that get in the way of helping people create their best lives. Our other colleague, I don't know if she's on, Dr. Meg Tomcho. Tomcho is the medical director of the Westside Pediatric and Adolescent Clinic at Denver Health. She's been with Denver Health for about 10 years, previously practiced in rural Western Colorado with the National Health Service Corps. She is passionate about integration of behavioral health and primary care and using patient navigators and promotors to help families better understand care and access services. So Meg, are you there somewhere? Can you unmute yourself if you're there? Well, maybe.
Does that help?
Oh, there she is.
Can you hear me now?
There she is. Hi, Meg.
There.
So Jody and Meg are here to provide some reaction and response to the trial and the Navigator program from their perspectives at Rocky Mountain Human Services and at Denver Health. So I don't know which of you wants to go first.
Do you want to start, Meg?
You can start. You're there.
So, so this was an interesting and complex kind of trial to implement, and I think there were a ton of lessons learned in terms of what just really seeing all of the barriers that our very complicated system puts in the way of any family, but then particularly families that have additional barriers of language and culture and things like that in their lives. And so, so I think that we absolutely saw that there was some impact, certainly, of the navigation, and it's really shaped kind of my thinking about not just how to help remove the barriers for autism services, but for early intervention in general. And so with Meg and with other folks in the community, we've continued to kind of work on strategies to expand this. And one of the things that we're doing at Rocky Mountain right now is we're in the middle of interviewing for a newly created position that we're using some mill levy funding that we get from the City and County of Denver. And we are gonna hire an EI engagement specialist. And a lot of that thinking came out of this work. And initially we were thinking about hiring a navigator. And then we recognized that having just another person that was going to try to, meet all of these different needs of people, not just from Denver Health, but referrals from other clinics in the community, that we would probably need an army of navigators, and that wasn't quite realistic yet. And also we weren't sure that that was going to solve all of the problems that we were seeing. And so we're hiring this position, and we think that in the first year, what they're really going to be doing is working both with our families, but also with our community partners in terms of evaluating what are some of those barriers. I mean, we know some of them, but then piloting some of the solutions, and really then thinking about what might we be able to scale up in the future. So we're absolutely going to take the learnings from this and then expand them further.
Are you ready for me?
Yep. Meg,
Okay.
What would you like to add?
This was a wonderful project, a huge learning experience, a big lift for Denver Health, because it was right at the start of our autism screening. So we hadn't been doing the MCHAT prior to this, to participating in this. So that was a practice transformation project in and of itself to get that rolled out to all of the clinics, family medicine and pediatrics. So that turned out to be a fantastic learning experience and project. I think one of the biggest takeaways for me was just how important it is to have staff embedded in the clinical setting, so that when a medical provider sees a need for navigation, whether it's due to a positive screen or something that comes up in the visit, having a warm handoff and having that person in the visit at the time, in the clinic at the time of the visit, is so important. Our families have so many things that are competing with the needs, even with the medical needs of their child. And so as soon as they leave the clinic, oftentimes what was discussed at the visit it just doesn't become as important. So really working with the families to meet all of their needs, as much of their needs as possible in the clinic setting. It also was a really big learning experience for me too, around provider and staff education, in terms of developmental delays and diagnosing those, communicating those with families. And as Jody said, we're also working to really try to improve our communication so that it is culturally sensitive and appropriate with our families, to allow them to realize that these early intervention supports are just that, they're supports. They're not, hopefully not stigmatized in terms of the child having a problem, but more enhancing a child's development. And I think that sort of flip is is really important to get families to buy into participating in the services. But it was an interesting trial, and I do look forward to a lot of the stuff that we could learn from this in terms of getting more promotors, more navigation, more people that can really help families understand what it is that we're discussing at a visit and help them to carry out what needs to happen after the clinical visit.
Something that you said, Meg, reminded me of another point that I wanted to make about folks being embedded. I think when you look at that sort of cycle of things that have to happen in order for the child to actually get a diagnostic evaluation, the reality is, I mean, it looks something like this. A physician does a screening, makes a referral to early intervention, somebody from RMHS contacts the family, and then, you know, things can fall apart there because they might not answer the phone, or, you know, there's been a gap of a couple of days or something, and life happens. Then once that happens, we schedule them with, if we're able to get in touch with them, we schedule them with actually Denver Public Schools to do an evaluation. That's a whole new system that we're introducing, and they do the eligibility evaluation, which, you know, might take, you know, 6 weeks to get scheduled. Then the IFSP is written, and then if the referral was for autism, then we have to, the service coordinator has to make a referral to our internal clinical team to do the autism evaluation, which also takes some time. There's so many legs in time. And so one of the things we're really trying to think about, and I hope this new role can help us, is there a way that we can just be on the spot when a referral is made, and rather than, you know, make a referral and then somebody else has to call you and somebody else to kind of get that scheduled? Or boy, wouldn't it be great if we could even figure out how to make an evaluation happen right then. So lots to figure out, but I mean, any family, it's amazing to me sometimes that they make it through that.
Yeah, I agree with you.
I have a comment that's for both of you. Hi, this is Brian B., Self-Advocacy Coordinator at JFK Partners, and I have a question that I think is both for Meg and for Dr. Jody as well, both of you. Dr. Meg, you mentioned about if you're getting an early intervention referral or navigation referral or whatever, culturally speaking, provider and staff education, developmental disability, this is about enhancing development. This is not about your child has a problem. Okay, that's right. Thank you, that's key. How does that tie into this new job position about EI engagement specialist? Where does the rubber hit the road so that they can help that happen?
That's a great question. And as we're developing this position, I really want to think about that. But I think that what I envision is that they will, first of all, we're going to hire someone who is very well versed in EI already. I think that having to train somebody in early intervention and our complicated system would be 6 months before they were able to do anything effective. So we're going to hire somebody who already has a great understanding and really understands the ability of EI to enhance development and not just to identify problems. So if we hire the right person, they'll be able to assist with that. But I think there's also this component of their ability to talk with families. It's pretty likely that we're going to hire someone who's already an EI service coordinator and someone who has that great ability to really be strengths-based and engage with families in that way, and also the ability to engage with physicians in the community and other community stakeholders and help to kind of carry that message and also support others in carrying that message. So it's a big lift. I don't know, Meg, if you have any other thoughts about that.
I think it sounds like a wonderful position, and I'm excited to see what turns out, what happens. Yeah.
So given we thought, and part of that was working with Jeanette at El Grupo Vida, that sort of community outreach was potentially useful. Is there any thought that the engagement coordinator would do any of that kind of community partnering, community outreach, separate from children who are actually referred?
Yes, absolutely. We, in fact, that's been one of our challenges in interviewing, because there are people that are really great and comfortable with families and people that are really comfortable with community outreach, and they're not always the same person, but we're really looking for both. And I think we've got some strong candidates, so I'm excited. I think it's going to be a tough decision. But that, I mean, that list on your slide of all of the activities, systems level as well as individual family, we really kind of want to hit that all. And then my thought is, if this is successful in the first year, we're going to really identify like, oh, these were the interventions that were most successful. And so we want to see if we can get more funding to hire some more positions to do this. So maybe community outreach is super important. Maybe the direct family interaction is super important. Maybe they're all important. So we'll see where this goes.
Mm-hmm. One other thought I just wanted to ask Meg to mention. I think we did some training of, so talking about embedding navigators. So you all have existing navigators. And so I think we did some training to, of your existing navigators about autism, because it's a whole set of systems and processes they wouldn't normally be negotiating. Is that
Right.
Yeah, and I think that's one of the things I envision for this role too, is we don't want to be redundant to resources that already exist in the community or in clinics or healthcare systems. We really want to enhance that. And so where there's great navigation, like at Denver Health, those folks are navigating across a wide range of things, right? And so they're probably not expert in early intervention or autism diagnostics or things like that. And so we want to support those folks, not replicate the work that they're doing.
It was really compelling seeing the slide with the 54 unique activities that a family navigator does. It went through my mind.
Yeah.
These people are like superheroes and Swiss Army knives that have to do a little bit of everything. I'm curious if you have a sense of those 54 activities, or I think it was grouped into 8, which of those were highest impact in helping a family then move on to the evaluation?
Do you want to respond to that, Meg, or?
I think it's a good question, and I don't know that I could come up with like 1 or 2. There's probably a handful, just depending upon the family's needs. That getting the appointments is just so, as Jody mentioned, so complex that there are so many pieces that come into play. I think, at least in my experience in working with navigators for a wide range of issues, it's really explaining in a way that's familiar and culturally sensitive to the family, interpreting what the medical provider is saying to the families in a way that they understand. We try, but don't always get the traction that I think people from the community are able to accomplish by using like familiar terms and in a comfortable manner. And so I think that probably played, particularly with this autism, played a big role in allowing the navigator to provide just some comforting information to the families, to attend the evaluations with them, to be there with them. But all the other things, transportation, scheduling, interpretation, those are all absolutely essential as well. So I'm not sure if there's 1 or 2 things, but probably a whole bunch of stuff. Jody, do you have thoughts?
Yeah, I'm not sure either. I think I'm probably looking at it from the lens of what I would see from the Rocky Mountain Human Services standpoint. And I think that maybe it was, I mean, this is the care coordination, but I might call it bird dogging, you know? So really when, oftentimes, when the navigator would contact me or one of my colleagues and say like, oh, this family's falling through the cracks, and oftentimes it was kind of like, your people aren't calling. and then I would look in the chart and I would see this, wide, long list of like people reaching out in this way or that way. But it was that you know, either they reached out and didn't, you know, get in touch with the family member, or the family member didn't understand who was calling them why. So it was that kind of combination of making sure to like close all of the loops and tie everything together to like actually make it happen.
There's a question online.
I don't know how to do that.
Do we know if any of the families who participated in this study also are part of the Healthy Steps programs that exist at Denver Health? And what was their role in all this process?
Meg, do you want to take that?
Yeah, I saw that question, so I've been trying to think about that while we were talking. I don't know if there were crossover between the participants in the study and the Healthy Steps. I don't think so. I'm trying to think of the time, how the time course played out. Our Healthy Steps specialist, and we also have an early childhood navigator that's associated now with our Healthy Steps program. They do a ton of similar work that complements what this navigator project involved. So, but honestly, I don't know. Healthy Steps, I think personally, I think that Healthy Steps would be a great way to keep this work going. One way to keep this work going, because it does provide a ton of navigation and family support. But I don't know if there was particular crossover.
There was nothing recorded about it. Do you know the timing of when Healthy Steps was initiated?
Yeah, it was started in 2015 here, but started with just babies, so they wouldn't have been old enough to get the MCHAT at the time.
So, and I think we finished our last, and we were just trying to remember, 17?
Yeah, so maybe at the tail end there would have been crossover, but not much.
It was 2018, so that we finished with the last, you know, the last few months of the final enrollment. So maybe they would have been too old.
So Jody, Carolyn mentioned that at one point there was a year wait list for the in-house team at Rocky Mountain. Was that?
Yeah, that actually surprised me. I don't think we've ever had a year wait list, but it may have been
was recorded or
exactly.
The family.
So I feel like sometimes that there would be this miscommunication around kind of what exactly was going on. But it is true. I was actually going to point it out. So Jana von Schultz was one of our psychologists at the time, and she was here for a bit and she had to leave. So she was a psychologist on staff and then left and went to children's. So, so we did in fact have a shortage of psychologists and an increase in our wait time. And what we do is we don't schedule our diagnostic evaluations out more than 3 months. And so when we got to the place where we scheduled out 3 months, and we would put people on a wait list, and then when we opened up the next month, we would contact them. So it typically, we're hiring a new psychologist, so we're in that same situation right now, and typically we are still seeing people within probably 4 to 5 months, and that's when we're slow to schedule. So it's not, it hasn't been a year, but it is. I mean, it's a significant amount of time in a little person's life, right? So it's not ideal.
And that may have been the family's perception of.
Absolutely.
But definitely there was, it definitely stretched way out toward the end of the study. And we had a whole slew of families who were ready to go, and we couldn't get them scheduled before the end of the trial. They just were sitting waiting, unfortunately. So, and there was wait lists for other things too, like Spanish speaking occupational therapy was an issue. So families were, the child needed OT, but there weren't any Spanish speaking OT, so there would be a wait list for that as well. And that wouldn't necessarily be related to you, but it was definitely, there was just, that's another problem that's sort of outside of this navigation, is just a shortage of services.
Yeah. And the lag time. I mean, even you know, one of the things that I struggle with about early intervention is that we can still be in compliance with all of our contractual regulations, and it is 2 to 3 months before, from the time of referral, before a child gets services, which is a really long time when you're concerned about your toddler, right? And then if you throw in the autism diagnostic evaluation and then any additional services, it's like it keeps dragging out beyond that. And so it's something that I really want to think creatively about how we can operate a little bit differently and shorten those timelines, because it's all well and good for us as a state or a community to say like, oh, we're 95% in compliance with our timelines, when our timelines aren't really that great to begin with. You know?
Does the child and family have to live in Denver County to get an evaluation at Rocky Mountain?
So that is a great question. So the answer is maybe. So if a child lives in the city and county of Denver, we know that we can provide them with an evaluation because we have multiple funding sources. So we are the EI provider only for Denver County. So if a child lives somewhere else, they can't get services, including autism evaluations, through us. However, we can provide services to people who live outside of Denver County if they have a means to pay that covers the cost of the evaluation. So right now, with our small number of psychologists, what that really looks like is we're a contracted provider with Kaiser, and so we take referrals from Kaiser, and we will see kids wherever they live. But we are not really marketing our services beyond Denver County, because in Denver, if a child is under 3, we know that we can use EI funding to provide those services. And also we have this mill levy funding that helps to support, but we can't use that funding for anyone who doesn't live in Denver.
So, and I think the point was made in the presentation that if there's a wait for the autism evaluation, a family can still get engaged in early intervention services and receive any of those ongoing services. So that the wait for the evaluation isn't a barrier.
Yes, absolutely. And that's a good point. And the other thing is that in the beginning of this, what we hoped to do was, if a child had screened positive on the MCHAT and was referred initially with that autism evaluation referral along with an EI referral, that we would simultaneously do both. But what we learned was that we couldn't do that because we couldn't use early intervention funding to support the autism evaluation until the child was found eligible for early intervention services. So we had to do those sequentially, which was like one extra thing for the family, but they were already at least getting the early intervention services. So they'd be found eligible for early intervention, begin services, and then get the autism evaluation.
Has there been collaboration with the school system, meaning Child Find, to help with possible solutions to evaluation that might offer some other creative opportunities like joint evaluation or evaluation in school settings?
So that is a great question. We collaborate very closely, like probably every single day, with Denver Public Schools because they're providing the Child Find evaluations. One of the things that is challenging is this kind of early intervention in some ways kind of blends a clinical model with an educational model. And the school is just doing an educational model, right? And so, so even as recently as like a week or so ago, I had a call from my friend and colleague at Denver Public Schools who said, oh, I'm getting some complaints from our higher ups about the fact that your team, because sometimes we do, just to complicate things even further, when Denver Public Schools can't get all of the child find evaluations done in a timely fashion, our team will also do those. So my team did an eligibility evaluation, and during it recommended an autism diagnostic for this family, and the folks at Denver Public Schools were like, you can't do that. As an educator, you can't make this recommendation, you're not qualified. And so I had to explain that in fact we have a clinical team and they are qualified to make an autism diagnostic. So there's a lot of translation between the educational and clinical system, and everybody's doing their best work and really trying to collaborate well, and sometimes we just get, you know, trapped in our sort of silos around that. But I think we are super open to thinking about ways to embed, collaborate in lots of different community settings, because we know that going where kids are and families are is going to be more helpful than trying to, you know, force them to fit into our little paradigms. And that actually reminds me of one other thing that we do that I still don't know of anyone else that does this routinely, is our team actually does the diagnostic evaluations in the family's home. So that's another way that we try to get around a barrier.
I just wanted to note that based on the notes from our navigator, that barrier can operate both ways. There were families, particularly undocumented families, who did not want people coming into their home. And that was one situation where they would ask the navigator to come also to sort of maybe help them a little bit. But so having it in the home has a lot of pluses, but maybe a few minuses as well.
That is a great point. And one of the things we try to remind our schedulers to do is to offer that they can come into the clinic, but since it's so rare that families want to do that, they sometimes forget. But that is a good point. Not everyone wants to have, for lots of reasons, you know, maybe you don't want that, you don't want to have that very stressful kind of evaluation happen in your house where you have to think about it every day when you're in your kitchen or whatever.
If I could jump in on the location of the evaluation, we do those here at Westside, or the Child Find team does IFSP, so not autism evaluations, but does them once a week here at Westside, which I think has been a huge, hopefully a huge positive in terms of locating those evaluations in a medical home to just help families recognize the linkage between the pediatrician and the evaluation, and then can also be a comfortable place, sort of comfortable place for families to get these done.
When did that start, Meg? I can't remember. A couple years?
It's been a couple of years now, yeah.
Yeah, so I think that was an exciting development, and Denver Health has been an amazing partner since the time that I started in early intervention and really wanting to think creatively about how to meet the needs of families. And so we were excited to do that, and I would love it if we could expand that.
Yeah.
Meg on the phone, could we ask her that question about the screening test? We asked her earlier and we weren't able to answer.
Sure, she might know if I didn't have an answer.
So Meg, is the level 2 autism screener stat ever used after the MCHAT-RF?
Not in the primary care setting. I'm not sure if our outpatient behavioral health services uses it, but we don't use it in our primary care clinic.
And this is for Jody. Do your service resource coordinators receive any training to further their knowledge in cultural practices, like working with monolingual families?
Yeah, that's a great question. We do some training. I think we could and should do more. One of the projects, and I'm not involved in this, so I don't know as much about it, Meg. I don't know if you are, the non-English, non-Spanish speaking families. So one of the things initially when I was planning this position, I was originally like, oh, we need to hire someone who's Spanish speaking. And then I was like, oh, but I know that we actually have even more difficulty with our non-English, non-Spanish speaking families, and we're not going to be able to find somebody who speaks every language. So, you know, what do we do? And so one of the things that we really focused on in hiring for this role was cultural competence, cultural openness, things like that, because regardless of what the family's culture is, we want to be able to meet their needs. But I think that's a great question, and I think we could do more to train our service coordination staff in that.
I wanted
Yeah,
to, go ahead, Meg.
our Lowry clinic, where there's huge diversity, is Jody, the one that you're talking about, that's working particularly with our non-English, non-Spanish speaking families. And I don't think that there's one or two languages that jump to the top of the list. Again, it's just so diverse, and just cultural humility in general is so important, and openness, and just kind of being along with the family and asking them, how do they interpret their child's development, and what do they see are as potential supports to enhance it. But it's tough. I agree with you that I had the same thought around the Spanish speaking navigator, that it might be better to look at the non-English, non-Spanish speaking families that really struggle.
Mm-hmm. And I wanted to mention that there was a proportion of the children randomized to the intervention group who were non-English, non-Spanish speaking. 0% consented to navigation. So none of them were comfortable with the process or the people.
I was really intrigued, Dr. Litford, about, as you describe, embedding expertise and maybe even a psychologist in the primary care setting or pediatric setting to do the evaluation on site. And I'd love to hear a little bit more about that and what that ideally looks like. Is it a psychologist? Is it some behavioral health specialist? Is it a care navigator?
Yeah, so great question. And I think I really want to have some humility and work with the folks that are in these sites and in the community to really think about that. Because one of the things I know is, for instance, with Healthy Steps, there are behavioral health folks on site that have expertise in child development. And so we don't want to replicate that or be redundant to that work. But if there is a place where we can enhance it, we absolutely want to do that. And I've definitely thought about this notion of this gap between referral and then our intake folks calling. And so if we could have an engagement specialist, a care coordinator, or somebody who was on site who could have a warm handoff and actually do the intake and get the evaluation scheduled right then, that would be a huge win, because I think that place is where we lose the biggest chunk of kids, but then there's also a big chunk that we lose between intake and evaluation. And so so the more that we could do on-site evaluations as well, similar to what is happening at the Westside Clinic, I think would be helpful. And so that is a team of, right now it's Child Find team, but they have speech, OT, PT, et cetera. They're not doing diagnostic evaluations, they're doing developmental evaluations. We're also talking with a couple of other community partners like early childhood centers that have a pretty big population, about potentially embedding there, and maybe even, I mean, one of the things, even though we do most of our work home-based, we our offices are in a place that is not central to Denver and not near where most of our kids and families live. And so even thinking about having some satellite offices that are embedded in the communities where we're interacting, we have the opportunity to interact with other providers, whether it's medical providers, childcare providers, et cetera, and kind of building that shared knowledge and expertise so that we can all support our families better are some of the things that we're thinking about doing.
So it sounds like we are creatively thinking about other options, and I don't think I've heard it yet. Lay interventions, peer support, other parent groups. I haven't heard that here yet, but while somebody's in transition or whatever, or until you embed somebody in the clinic or that kind of stuff, can we tell them, oh, there's a monthly potluck at Children's Hospital. It doesn't matter if you're from Yuma County or whatever, you can go there. And I don't know, I don't think they have any tech ways of tying in remotely there yet, but the ARC in the chapter that you're at, are we doing any kind of, please talk about that, or if we're about out of time here, I just wanted to put that in, as the self-advocacy coordinator, a lot of times I'm looking at how can people with lived experience contribute to the workforce of the professionals and those that are licensed to serve the communities.
Yeah, that's a great question. I don't think we do some of that, and we don't do enough of it. And that is one of this position has gone in my mind through lots of iterations before we eventually developed it. And one of the iterations was really thinking about, boy, wouldn't it be great if we could hire a parent in this role who's been through this system? And that's not off the table at this point. We didn't have anyone who applied for the role who fit that criteria, but we might develop more of those roles down the road. That's certainly something. But I think thinking about resources that are already out there and how we can more intentionally connect families with those resources is a great idea. I don't know, Meg, if you want to add anything to that.
No, just ditto what you said. I agree.
So online, we have someone who was in a previous role in Massachusetts Healthy Steps, and they were able to complete the EI intake within the clinic setting, and they were very successful with the types of families you're describing.
That's awesome.
That'd be wonderful. That'd be really great.
Well, thank you very much. We all appreciate the opportunity to tell you a little bit about what we've been working on in this area, and thank you all for participating.
Yeah, thank you. Thanks.